Professor at PGIMS Rohtak, and she practices oculoplasty, and her talk is on cicatricial ectropion. Ma'am.
Thank you, Dr. Rachna. Okay, we move on to ectropion. Cicatricial ectropion I'll be covering mainly, remodeling with 5FU along with the definitive management. Ectropion, as you know, is a commonly encountered eyelid malposition. It is characterized by rotation of lid margin outwards, resulting in its fall away from the globe. It involves the lower lid more commonly than the upper lid. It can be involutional, paralytic, cicatricial, mechanical, and very rarely congenital. But we'll be covering mainly the cicatricial. These are few cases I have dealt with of cicatricial ectropion. It is usually associated with the shortening of the anterior lamella, the skin and the orbicularis muscle. Etiology is mainly any prior surgical resections of tissue, burns, any actinic damage, autoimmune diseases, or any chronic inflammation. Chemical burns of the eyelids are common, and this may lead to ocular damage. Wound contracture can cause the ectropion of the eyelid, and lower eyelid, as I told you, are more commonly involved. The clinical consequences can be both functional as well as cosmetic, and if untreated, they may lead to keratitis, scarring of the cornea and conjunctiva, globe perforation, and also rarely may lead to blindness. Common indications are generally documented ectropion with chronic eye irritation despite topical lubrication, exposure keratopathy, chronic keratoconjunctivopathy, tearing related to outflow, related to reflex, or chronic dermatitis. Now, coming to the management part, it could be medical as well as the definitive. Medical, initially conservative management, temporary, but can improve symptoms while we wait for the surgery to take place. Lubricating the ocular surface is very important. Horizontal taping of the eyelid, hyaluronic acid filler injections can be done, and scar modulation is the latest. Lubrication and moisture shields are important. Plastic dressings are often superior to cloth patches. Taping the infralateral canthal skin supratemporally provides temporary relief. If the conjunctiva is markedly keratinized, a lubricating ointment should be used prior to the ectropion repair. Corneal epithelial defects and prior herpes simplex infection are a relative contraindication to steroid-containing ointments. Hyaluronic acid filler injections are one alternative. They can be successfully used by they expand the tethered anterior lamella of the skin. This provides an effective alternative to surgical correction of the lid, and the treatment is quick, safe, and easy to learn. Coming to the main part, the scar modulation. More recently, progress has been made in modulating overly aggressive wounds still actively involved in the scarring process by using several injectable drugs. One of them is 5FU. It is an anti-metabolite that works by irreversibly inhibiting the enzyme thymidylate synthetase, resulting in impaired DNA synthesis. This reduces fibroblast proliferation and inhibits collagen type 1 production, which is a key protein in scar formation. Subcutaneous injections of 5FU, 50 mg per ml, can be given to patients with periorbital and lid scarring every 4 weeks for a total of up to 6 injections. At each visit, patients are evaluated for redness, swelling, tissue inflammation, telangiectasis, and pigmentary disturbances. Intralesional 5FU for scar modulation is an off-label use and should be avoided in active chronic infections or immune depression of pregnant lactating women. This is a small video of it's a very cheap drug available. The vial is of 30 rupees only, or 40 rupees. You just take it, inject lignocaine first in the scarred area, followed by 5FU. We can take it in a 1 ml or an insulin syringe, and just around the scar area, all around the scarred area, you can just give 2-3 injections. And it has really given dramatic results in patients, especially the symptomatic relief. Next visit, the patient will tell you that the stretching effect has reduced. So even after the first treatment, the cicatrix is a little softer and more mobile, sometimes less fixated to underlying tissue and described as less tight by the patients. These improvements may continue over 3 to 5 treatments. Although there can be some temporary swelling and redness for 2 or 3 days, risks are minor. A topical anesthetic cream can be used. These are few cases I'll show you which have been treated with 5FU. We can see that the amount of cicatricial ectropion, it also decreases. Mild cases I have seen that they have shown good results. The fullness of the scarred area that comes and the relief that the patient feels is quite significant. This patient had a notching in the upper lid which reduced a little after 2 injections of 5FU. This was another patient. You can see closely that there's a reduction in the amount of the lid touching the globe has increased. This patient was not able to close her eyelid, but after few injections, 3 or 4 injections, she was able to close her eyelid properly after the injections. This is another patient of medial cicatricial ectropion with the periorbital area, which showed, you can see the scarred area, the amount of improvement we can see there. Another patient which we treated with the same technique. This is another one. So this is a very good modality nowadays to definitely go ahead with 5FU injections. And followed, obviously, very advanced cases cannot be treated with it, but they definitely give relief in symptoms, as well as the surgical management also becomes easy, because the fibrotic part, it becomes softer to deal with. So coming to the surgical management, these are few similar cases of post-traumatic cicatricial ectropion who reported for management, and similar steps of surgery were performed. Patients reported with history of mild pain, redness, and watering. Visual acuity was normal. The lower lid of the involved eye had developed contracture due to the injury. Scarring was present in the lateral third of the lid in 3 and in the medial third of the lid in 1, along with conjunctival dryness. Ocular movements were full and rest was also normal. 3 injections of 5FU were given at an interval of 4 weeks. Softening of the tissue was observed and symptomatic relief reported by patient in reduction of the tightening effect was there. However, the complete cosmetic effect we cannot give in advanced cicatricial ectropion, so we need to go for the surgical management. So it often requires lengthening of the anterior lamella by a skin graft. I'll show you a few steps. I have a video, if time permits, I'll show you. Patient was managed by releasing the skin contractures with incisions running along the eyelid margin down to the orbicularis muscle. A subciliary incision is given and the fibrotic tissue is removed after additional dissection. The lower lid is released completely so that it can be freely mobilized. Horizontal dimensions are measured. The vertical dimensions at different places are measured, not only the central and the side. And then if the graft size is appropriate, we can use the retroauricular area, or if it is too large, you can use the supraclavicular area also. So retroauricular measurements are taken. The graft size has to be kept a little few millimeters more than what is required at the host junction. So graft markings are done, local anesthesia given in the retroauricular area, skin incision given to raise the graft, skin undermining and dissection is done. The skin graft is raised. After this, the graft is thinned of all the subcutaneous tissue so that only dermis and epidermis remain. It is placed over the defect. It is sutured into position with 6-0 silk sutures, completing the graft suturing, and few stab incisions are given over the grafted skin to relieve the hematoma in the first few post-op days. And frost suture is taped to the forehead, and a double eye pad is placed over the repair for 48 hours, followed by antiseptic dressing. So you put a bolster and you give us compression at the site of the I think I'll show the video in the end. So this is the post-op result. In the initial first, after 48 hours when you open the bandage, sometimes it is a black ishar which is formed. First time when I had operated, even I had got scared what has gone wrong. But it is the normal appearance. Slowly and slowly this black thing will take the color of the normal skin, and it really gives you good results. And obviously you have to take care of the retroauricular area where you have taken the graft. So these are the results. This is the pre-operative after 4 weeks of skin grafting. The skin generally merges. A little bit of cosmetic blemish is there, but it generally merges with the surrounding skin. This was another case with relief of the cicatricial ectropion. This was post-operative 4 days. You can see the amount of stretch, how much it is relieved after the thing. This was the case of medial ectropion, which we had dealt. In this case, because the canaliculus was also involved, we had used the mini Minoka, followed by, we did not need the grafting in this. Simple dissection and suturing was helpful after passing the mini Minoka. So this was the post-operative result. Coming to the complications, ectropion surgery is considered safe and effective. Recurrence does occur occasionally after several years, requiring a repeat surgery. Like any eyelid surgery, there's always a possibility of local post-op bleeding or infection, but these are generally minor. Injury to the cornea may be possible. It is a clinical situation, ectropion, where the lid margin falls away from the globe. Cicatricial is generally secondary to trauma. Factors which include vertical skin shortage, contracture, and horizontal skin laxity, and deficiency of muscle may accompany. And severe cicatricial ectropion creates a marked aesthetic deformity and poses a risk of corneal exposure, and so mandatory is the treatment. It's a real challenge to the ophthalmologist and plastic surgeons. There is often inadequate muscular support for the pretarsal lower eyelid. Treatment is centered on release of the cicatricial changes. Full thickness skin grafts are most commonly used to manage such ectropion, and surgical complications I have discussed. So coming to the conclusion, post-auricular skin graft in severe cicatricial ectropion provides good cosmesis and relief from the symptoms and early prevention of exposure keratitis secondary to the ectropion. Do we have time for the video or you want to listen?
Thank you, Dr. Urmil. That was a wonderful talk, I would say, and amazing results with 5 fluorouracil, which you have shown. Just few questions, if you can answer.
Yes, ma'am, why not?
Are there any changes in the skin color with the use of 5 fluorouracil?
No, ma'am. My very mild, 1 or 2 patients came with very mild itching problem, but there was absolutely no changes in the skin texture. In fact, the patients are very, very happy. They come, when I call them for after 2 weeks, they are extremely happy because that wo jo khichawat and jo stretching effect is there, that is dramatically improved. They feel softening and they feel the effect very nicely. And after 2 or 3 injections, it is really good. And there is no, particularly no side effects have been seen as of now. I have been following them for more than an year or 2 years. In fact, respected Dr. Khurana sir had started this in our department, and he is my mentor. He just started, but we are just following his steps, and it is really giving us good results. And the surgical management also becomes very easy because removing the fibrotic tissue after it has got a little softened is very effective.
So what cases you feel that this will work alone? Where you
very,
feel
very
that
mild
surgery
ectropion
can be avoided?
Very, very mild ectropion. Very, very, like I showed you 2 cases in which one, the lid could be closed, and in which another one, there was a very mild. I have treated 2-3 cases of very mild ectropion with only 5FU. The lid which was not touching the globe, it just gets a little softened and it touches the globe, and mainly the symptoms of watering and other problems are relieved, and the patient does not feel the need. The cosmetic problem is not that much that he wants a surgical treatment.
I think I must congratulate you for the wonderful results you have shown. Thank you, Dr. Urmil.
Maximum literature I have seen, 6 injections have been given. In one sitting, we are giving around 1 to 2 ml. Okay, and we are repeating after 4 weeks, but right now I'm also doing a thesis on the same topic, and we are comparing 5FU alone with 5FU plus steroid. And that is also a good thing, and we are repeating it after 2 weeks. So maximum 4 injections we are planning to give. This was when I was repeating. I'm telling you, right now I'm doing a thesis on this, in which we have also trying to repeat it after 2 weeks. Yeah, no, the ampule is quite big. It is 5 ml. We are just taking 1 ml out of it, 1 to 2 ml maximum. Depending also on the scarred area. Sometimes the scar is very small, so you need just 1 ml. But sometimes it is a big scar. Then you can inject 1 to 2 ml. It is all around the scarred area can be covered. No. Okay. No, I have no experience.